Today, we pause for a moment, not to examine the illustrious career of Regi, his achievements, or distinctions, but to listen more closely to the quieter story that lives beneath them. Behind every clinician, there's a great deal of compassion and unrelenting passion for patient care. Behind every academic contribution lies a curiosity that refuses to settle. And behind every leader stands a human being shaped by moments both seen and unseen. Today, we hope to glimpse that person. We're going to explore the values, the experience, reflections that shape not only what he does, but who he is. By the way, Raji is a great friend and colleague of mine, but that will not stop me from being brutally honest and objective about who he is. Hi, Raji. Is it okay for us to tell me a little bit about your experience as a psychiatrist? When you are not a clinician, teacher, or a researcher, who are you? Hi, Raji. Can you tell me a little bit about who you are when you're not a clinician, teacher, or researcher?
Thank you for the question anyway, Mirza. It's one of those things, isn't it? You get so lost in your identity as a clinician, as a psychiatrist, and so on, that often you don't pause to think who you are otherwise. I'm glad you asked me that. Maybe I should start in the conventional way. I'm 60 years plus, although I don't like to advertise that fact too much. But um, yes, and like most people, I am a son first and foremost. I have a 91-year-old father. I have a mother who is in her mid 80s. And they are parents I still look up to in my life, and I try and live up to the values they tried to instill in me. So I am a son from a distance at times, but I hope the mental distance is a lot less. I am a father to a daughter who's a general adult psychiatrist, and a son who has chosen a career away from medicine, but equally good as he uh, tells me. Um, Perhaps you'll have to talk to them about how they think I'm living up to the role of a father, but perhaps not wholly or in full measure, but I hope very substantially. And that is another identity. And then, very importantly, I'm a grandfather to a 4-year-old who thinks she's turning 18 next month. And that too is a role that one draws a certain pleasure from. And above all, I am a partner, a husband to someone who I met when I was 16, when I got married at 23, and I can say with some certainty, arguably a little bit of more certainty than I had for the other facts, that if I look back over the last 30, 35, almost 40 years now, um, that has always been an anchor of strength around which life revolves. So I'm afraid that is a rather personal answer, but then you asked for it. So let's leave it at that.
Well, that defines us who we are, and that's the reason why I asked you that specific question, because these lives, our personal lives and professional lives, constantly intertwined. There's no, we cannot escape from that. And but my first next question is really about how you got very close to psychiatry, not only as a profession but as a calling that kind of stayed with you.
Glad you asked that, because that is a question that I was asked for a psychiatry newsletter the other week by one of our um, SBRs. When I was a student in school in the early years of what used to be college in India, I was someone who studied subjects with a passion. Okay, mathematics and history, my two particular favorites, and I'm not even trying to draw some sort of comparison between the two subjects because they are quite different, are they not? And looking back, one of the things I think is you are attracted to subjects not because of some intrinsic interest you have in those subjects, but because you are guided by role models. I had an inspirational mathematics teacher. I had an even more inspirational history teacher, the latter telling me that history is not a catalogue of events in chronological order, but how it is a subject that defines our present. So I, through school and college, I learned these subjects with a passion, and it was a passion that sadly I missed during my medical education. You sort of studied to clear exams, and I must say, I did clear exams, but did not learn with a passion to the extent that by the end of my medical education, I was almost thinking of alternative routes and so on. Um, and that is when um, I went and worked in a de-addiction center, and I met an inspirational psychiatrist there, an inspirational man who showed me the link between, addiction, a fact of everyday life in Kerala those days, and mental health, and the dividing line with mental disorder. And that is how the interest in psychiatry was sparked for the first time. And he also advised that if you were to learn psychiatry, you should go to one of the better national centers, either the National Institute in Bangalore or the Medical College in Vellore and so on. So that is how the interest started. And um, to cut a long story short, I got into NIMHANS in Bangalore. And this gap in passion that I talked about, well, that disease was completely cured in the first 3 months of the NIMHANS posting. You suddenly discovered that there was a science, there was a certain rhythm to the science and practice of psychiatry as a branch of medicine that encouraged you to ask questions and to examine facts which go beyond planned medical detail. And that is a passion that has stayed with me uh, throughout my professional career, at least until now. Um, and I think that has been a long innings. So that's a rather long answer to your question, but I hope it captures the key point.
Absolutely. I mean, I think I'm somebody who had a similar sort of experience and of being in demands where I really learned the true understanding of learning and the passion for psychiatry, so I can relate to that. But can you tell us a little bit about your rich and illustrious clinical career, particularly talking about a patient whom you remember so well, somebody who stayed with you, not because of what you did, but something that she taught you?
Yes, as you can imagine, 30 or 40 years in psychiatry, you have so many memories that it's almost like asking you who is your favorite child. And but I'll tell you a turning point in my life, which is not in my professional life, so to speak, which is not so much about a patient, but about the interface between a patient and a consultant, my boss at that time, a teacher. We're talking about, I started my post graduation in psychiatry in 1991. So we are speaking about the early 90s. And most of you who know that period would know that that was also the period when AIDS as an illness was very much um, capturing the public imagination. And in a country like India, there was a great deal of stigma and fear, raw fear associated with what you would do with an AIDS patient and so on. And at the risk of embarrassing her, I will name my teacher. This was Professor Shobha Srinath, who was the head of child psychiatry in NIMHANS at that time. And I remember coming to work one day, going in to prepare for the consultant ward rounds or Shobha's ward rounds. And there was this young lady on the ward who was menstruating at that time, and there was a rumor she was clearly having a bipolar illness. I'm not getting into the um, detail of that, but can you imagine a young bipolar woman who is menstruating, and a ward which is terrified, terrified that they will, um, because of a rumor around whatever behavioral factors, that she might be HIV positive or have AIDS, and people uh, refusing, almost being reluctant to aid her in personal care. And I'll never forget how Professor Srinath Shobha strode into the ward with me in tow and took charge and actually did something that others were reluctant to do, where, practically attending to personal care. And this is what happens in this field. You see, this field is full of people who are genuinely committed to patient care. There might be the occasional fear and um, reluctance to do the right thing, but when they see role models they respect do that. I remember half the, what in this country you would call healthcare worker workforce. We used different terms in India at that time, them being so almost appalled that this consultant was doing these things. And the real change is they see that someone like a professor in psychiatry can do this without an element of fear. And that means they too have permission to do that. And that taught me a valuable professional lesson. Don't tell other people what to do. If they are reluctant, show them that you will do it. And they will continue to do that. And it has a lesson that has stayed with me throughout my professional life.
Thank you, Reggie, for sort of reciting that beautiful, poignant kind of clinical situation. Can I ask a bit more of a broader question? Because you've been practicing psychiatry for a long time. In all years of your practice of psychiatry, what has psychiatry taught you about being human?
It's a bit too profound, isn't it? Yes, I don't know. There are various ways of answering that. Um, Psychiatry, in comparison to other medical specialities, um, arouses strong passions and opinions in people. Psychiatry is probably the only part of medicine which has an anti psychiatry wing. You don't hear anti oncology or anti rheumatology. That is perhaps an oddity, but it is also something that goes to the heart of who we are as psychiatrists. If you think about the underlying issue, ordinary words of the English language, ordinary words which define slightly unpleasant human experience, are also the same words that describe psychiatric syndromes. So, when does sadness stop? When does depression begin? When does anxiety stop? And when does it become an anxiety and panic disorder? When does a meticulous attention to detail stop? And when does it become OCD? We know that as psychiatrists, but for the common man, for the general public, that distinction is often uh, lost. And it is that distinction which defines a certain abiding human distress that we as psychiatrists are uniquely placed to explain to others. And that is why I think psychiatry should never be an apologetic add-on to medicine. Psychiatry is a branch of medicine, and I've said this so many times. You know, um, it is not just the medical model, it is the scientific model, where we seek not to prove what we believe, but we seek to disprove our assumptions and our beliefs, the concept of the null hypothesis. And I think every good psychiatrist should hold on to that thought.
Thank you, Reggie. So I'm just going to ask you a little bit about your research because As you know, you are, apart from being an excellent clinician, you have been an academic, clinical academic. What are the questions that still you keep you curious about after all these years? What kind of questions do you have in your mind that kind of keeps you awake at night?
Yes, there are so many things I can think about, but since you talked about research, let me say this. I've always been a practicing clinician, a 100% practicing clinician. And I often joke with my trainees that I am a practicing clinician who knows to count. And that is my research interest. Because for most people, research is something to do with testing out hypotheses, usually from an ivory tower. I think as a practicing clinician, everyone should have two questions. One, is your practice in keeping with acceptable standards of your peers? So that is almost the audit question. Do you practice to an acceptable standard recognized by your peers? And most people do that. The second question for me is much more crucial, and it keeps me awake, to use your phrase. You can do the practice to the very high standards of your peers, but does that make any difference? You can have 15 audit standards saying you should see someone within 3 weeks, you should write to the GP within a week of seeing them, you should do this, you should do that. But the crucial question is, does that make the blindest bit of difference? For all your hard work, does your intervention work? And I think that is a research question. And that is a research question that every half decent clinician should be interested in. I quite often hear people saying, "Oh, I'm so busy as a clinician, I don't have time for research." You cannot be a good clinician who doesn't want to examine your practice, the efficacy, the safety, and the patient experience of your practice. And if there is one mission that I have repeatedly stressed in my professional life, it is to break this almost artificial distinction between the clinician and the researcher. A focus on whether what you do makes the slightest bit of difference. In other words, research around the outcomes of treatment.
Thank you, Reggie, because I know that you're very have got an excellent track record in making your clinical practice really become a research base as well. That's something that you've done for this country. And I'm kind of really can see the passion behind your interest in seeing that there is no chasm between research and clinical work. There is a sort of famous saying by Greek philosophers that life unexamined is not worth living. And I usually paraphrase and say that therapy unexamined is not worth doing. So, how can we make it happen if you were elected as a president of the college to make sure that research is built into your ordinary clinical practice?
Thanks, Mirza. The conventional answer to that would be to quote a research strategy and an academic strategy and so on and so forth. And they are very, very important. And I am pleased that the college's academic faculty in particular is leading efforts for that. But at its basics, it goes to a deeper question. We should get rid of this idea of psychiatric exceptionalism, where we start believing and telling ourselves and convincing ourselves that somehow our specialty is so complex that outcome measurement is not possible, that the rigorous monitoring of whether what you do works is not possible. We have to uh, have a lesson almost from our medical and surgical colleagues who deal with equally complex physical conditions and have no qualms about measuring their outcome. And we should start seeing that as everyone's business. And that is an initiative that should be led by the senior most and the most well trained people in the room. And if we start doing that, that would be a crucial step in moving towards a world of clinician researchers. I quite often tell people that the largest naturalistic databases which have defined the progress in medical and surgical specialties have come from routine outcome measurements in our general hospitals. The breast cancer audit in this country is arguably one of the biggest in all of Western Europe. So is the um, interventions in cardiac conditions, the myocardial infarction or cardiac failure, and what are essentially outcome audits of those conditions completed by everyday clinicians. And we should discover that passion and the willingness to do that in psychiatry. And I think as an organization, the college can bring a lot of energy into that field. At the moment, I don't want to use the word siloed, but at the moment we seem to limit that to certain parts of the college, this center or that center, or um, this audit department, and so on. While the college as a whole should be encouraging practicing clinicians to implement that in their daily working lives. And we can do it. We can do it with the minimal of effort. What it really needs is the commitment from the leadership to do that.
Thank you very much, Regi. So, looking back, can you recall a moment of difficulty or uncertainty that quietly reshaped you as a person?
You know, difficulties and uncertainty is the story of my life, really. The more I have learned, the more I have read, the more experienced I have gained, the less certain I am about anything. And I have nothing but admiration for my colleagues who seem so certain about things, from their interpretations of psychopathology to their conclusions about the diagnosis and their views about uh, treatment progress and so on. If I have one regret, if and it is an ongoing regret, and it is a regret I hope to address to some degree. I've been in this country for 30 odd years. I came at a time when Virginia Bottomley was the health secretary in 1994. Everyone was saying the NHS was in a terminal crisis. I now live in 2026 where we have a different health secretary, but what has not changed is everyone saying the NHS and health service is in a crisis. If there is one change I have seen in the 30 or 32 years, it is an increasing specialization, particularly within psychiatry. So, specialist teams for A, B, C, and D, specialist teams which have their own inclusion and exclusion criteria, and specialist teams which deal with the upper end of complexity. The trouble with that, and that is my regret, the trouble with this kind of specialization is, unfortunately, it promotes silos. You get a whole category of patients in this world who are defined by the exclusion criteria of these specialist services. You get a whole category of patients who everyone agrees, no one has any doubt about the real and tangible distress they are going through, the distress of their loved ones, but everyone is also sure that they are not for our service but for someone else. And I think this is a crucial role for psychiatrists trained in the science of complexity to to assume a generalist role in tackling human distress due to pathology, a generalist role in saying the most competent and the most qualified should participate in the triage process, which decides whether someone is suitable or unsuitable for services. And there are so many examples. You asked for one example, but if I adopt this as a generic issue, there are so many stories of people I can recall who fell into this gap of everyone's exclusion criteria. And it is something um, that I am resolved to change. I try to change the system in my own limited capacity. I'm sure an organization like the college can change it in much more abiding and relatively more permanent ways.
Thank you very much, Raji. Is there anything that you believe now that your younger self would disagree with?
You're asking me to recall my story of regrets. My younger self was a lot more impetuous. My younger self was a lot more sure of myself. I thought I had an idea of what was right and what was wrong. I thought I knew which countries were right and which countries were wrong, which philosophy was right, or political philosophy was right and which was wrong. As I said before in reply to your earlier question, the more I have learned, the more I have read, the more experienced I have become in life, um, I have learned to appreciate shades of gray rather than black and white, and yet shades of gray which still allow you to make clear, clear moral judgments. I have learned to appreciate that there are no absolute heroes and villains. I have learned to appreciate that shades of villainy persevere and persist, but you have to actively seek out the more acceptable shades of gray, because otherwise you're left in a world where there is no one you can collaborate with. Um, this is true as much of psychiatry and medicine as it is true of world politics, and I don't need to set out the latter in greater detail for you.
Well, we will not go into that today because we got to finish this interview. But before that, I just want to ask you about your style of leadership, for example. If you were elected as president, which I hope you will do, what kind of culture would you hope to nurture within the college?
This is one of the reasons, Mirza, why I'm standing for the election. Okay, there is little doubt that the Royal College of Psychiatrists is one of the most influential players in this field. There's little doubt. Sometimes we underestimate our influence. The key word is influence and moral influence. We may not have power. We may not have power, but we do have authority and moral authority that comes from the consensus of our colleagues around us. But to exert that authority, we need to be a college that enthuses its members. And that is a field where we could do, I'm not saying we're not doing it now at all, but it is a field where we could do a lot better. We could move away from a system where 70 or 72% of people feel disengaged from the college, where an electoral turnout of 36 or 38% is treated as a record turnout. And the answer to correct that, the way to correct that, the way to become a college that enthuses its members is by establishing a system where the average member feels that the college is a membership body that exists for them. And sometimes it feels unfair, but nevertheless, it is true that many a member feels that the college hierarchy treats them as if they are a nuisance, or a nuisance is perhaps too strong a word. They are a slight distraction from the hierarchy's main work. I want to correct that impression. I want a college hierarchy, a college leadership, a college structure that knows fully well that they exist on member subscriptions purely to serve our members. And that might mean a difference not just in content, but also in the tone of how you interact with members. Most of us know it in our employing trust. It is not the salary we get or what um, people tell us day to day, but it is the feeling of being valued, the feeling that the hierarchy respects and looks forward to your views. And I want a college that will adopt that style, and I'll adopt a style of leadership that will facilitate that goal.
Thank you very much. What would you like people to feel, not think, but feel about you as a leader?
He's one of us. He's one of us because I am one of you. That is what I want you to feel. Because some people almost tease me for saying that this all the time. I am a full-time practicing clinician. Apparently, a couple of people said, well, you shouldn't say full-time and practicing because that is unfair to part-time and retired. Let me tell you, I'm not using this in the concrete sense. I'm talking about practicing clinicians who spend 100% of their practicing time um, looking after patients, looking to improve patient outcomes. And in that group, I include retired clinicians who have a wealth of knowledge that can contribute so much to those who are practicing today. And I think we can harness that power a lot more.
Thank you. I just want to ask you a last question. If a young medical student is watching this interview, not looking at your accolades, the distinctions, and all the awards that you won, the way you live your work, what would you hope they carry forward from you?
I think my junior doctors, as we used to call them, or my resident doctors and specialty doctors, as they are called now, would know this. And this applies to my research staff as well. If there is one lesson you want to learn from me, it is you're really not as busy as you think you are. I'm not as busy as you think I am. We all have time to do more, and we all have time for our fellow colleagues, for our patients, and those who come into contact with us. It is merely a question of setting priorities. Don't take your work too seriously. Don't go around thinking that what you do is so particularly unique that no one ever could do that, and that will keep you grounded, and that will also um, drive your desire to better yourself. Your aim should not be to preserve your standards. It should be to improve and go on to newer grounds. And you are not too busy ever to do that.
Thank you, Regi. If today has revealed anything, it is that behind the skill and scholarship stands a human story. A story that is unfolding, still questioning, and still deeply committed to the art of being both a doctor and a fellow human being. And he really values everybody around you, and he wants to bring some changes to the college. Thank you very much, Raji, for being with me. Thank you.
Thank you.